is our state-of-the-art 14-acre residential campus in Coburg, Oregon, just north of Eugene. We provide medically supported withdrawal management, residential and day treatment in a beautiful and supportive setting. Our services are for adults 18 and over. We offer trauma-informed, abstinent-focused, and patient-centered care utilizing innovative, evidence-based practices. We offer a medically driven MAT programming for patients who may benefit. We are a nonprofit and CARF accredited. Inpatient is just the beginning of our care. In addition to our detox and residential programs, 7 Oregon outpatient locations offer virtual telehealth services known as Recovery Now, along with our traditional in-person groups tailored to the patient's needs and offer IOP, Level 1, and DUII services. Serenity Lane's medical direct is Dr. Eric Geisler, who you will hear from in a moment, and our director of mental health is psychologist Dr. Cheryl Gifford. Our certified addiction counselors are joined by psychiatrists, our psychiatric nurse practitioner, and our team of mental health professionals to provide for co-occurring treatment. We offer a variety of specialty services for our patients, families, alumni, and employer services. Serenity Lane is in network with most commercial insurance companies. Please visit our website, www.serenitylane.org. My business development colleague, Steve Harris, and I will have our contact information in the chat. Please reach out to us with any questions, needs, or referrals. To avoid sound issues, you will be muted until the Q&A portion at the end of the presentation. At the bottom of your screen, you should have access to the chat feature and Q&A. Please place your questions for our presenters in the Q&A so we can be sure not to lose them in the chat thread. In the Q&A, you can see questions others have asked and upvote them, helping us to prioritize questions that are of interest to the greatest number of participants. Our first presenter is Dr. Eric Geisler, the Director of Medical Services for Serenity Lane since August of 2016. He is certified by the American Board of Addiction Medicine. Before Serenity Lane, Dr. Geisler managed his own family practice clinic in the Springfield, Oregon area for more than 20 years. During that period, he maintained privileges at both Mackenzie-Willamette Hospital and Peace Health facilities. He currently enjoys teaching psychiatry to resident doctors from the Good Samaritan system at Serenity Lane. He is also an affiliate professor for the Department of Family Practice for Oregon Health Sciences University, aka OHSU. Our second presenter we are honored to have is Dr. Kate Marshall, who is a current fellow in addiction medicine at Oregon Health and Sciences University. She obtained her doctorate from OHSU and completed residency in internal medicine at Providence St. Vincent Medical Center in Portland, Oregon. After completing her fellowship, she will take on the Samuel H. Wise Fellowship in General Internal Medicine with a focus on improving education in substance use disorders for internal medicine residents. She lives in Portland with her husband and daughter. Now, please welcome Dr. Eric Geisler.
All right, so I think I'm actually going to go first. I think Dr. Geisler and I kind of split it up, so I'm going to do the beginning. Dr. Geisler will do the second part. Thank you guys so much for having me. Just really appreciate the opportunity to be here. And looking forward to talking to you about this topic that is just so incredibly important and that I'm really passionate about. So I'm going to go ahead and share my screen here. Okay. All right. So just to start out with disclosures, I have no financial relationships, but I do want to give a heads up that this talk does contain images of alcohol consumption. It discusses consequences of alcohol use, and it has references to childhood trauma. So just a heads up about that. So our objectives today. So I am going to be today this a little smaller, great. Make sure that we cover the definition of alcohol use disorder. How does a physician actually diagnose that? We'll talk about the health effects of alcohol consumption on the body. We'll talk about the known causes of alcohol use disorder and what we know about the science behind why alcohol use disorder might develop in one person and not another. And then we're also going to discuss today how alcohol use affects women differently than men. So I'm going to start out with an example, and this is the kind of patient that I would see pretty frequently actually when I was working in the hospital as a general internist. We'll talk about someone named Sheila. So she's a 40-year-old woman. She has a history of obesity and anxiety, and she presented to the ED with belly pain and vomiting. Initial labs showed that she had elevated liver enzymes. And then they asked her a little bit more, and she said she typically drinks a 12-pack a day of beer and has been ever since the pandemic started. A CT scan of her belly shows an enlarged, inflamed, and fatty liver. And she is treated with IV fluids and medication for nausea and feels quite a bit better. She's advised to stop drinking alcohol and to follow up with her primary care provider. However, she then comes back to the ED 2 weeks later, not having had a chance to see her primary care provider, and she's worried about yellowing eyes. Since the prior visit, she says she's gained 70 pounds and her legs are now swollen. Her belly pain has just gotten worse. And she's found when she gets to the hospital to have worsening liver labs and now some evidence of kidney dysfunction as well. And she says she hasn't had any alcohol since last visit to the ED, and indeed, they check an ethanol level and it's negative. So she's admitted, and her diagnosis is alcoholic hepatitis, inflammation of the liver due to alcohol. And she also is admitted for acute kidney injury and for this worsening abdominal pain that needs to be better controlled. She's really scared. She knows alcohol is the cause of what's happening to her, and she did try to stop. She says she only found out about that her health might be affected by her alcohol use about 6 months ago when her primary care doctor told her she had mildly elevated liver enzymes and asked her to try to cut back. So this is where I meet her. I was on the addiction medicine service. I was consulted as part of her hospital care. And I got to say, this is not necessarily a specific patient, but it's the type of patient that I see a lot in the hospital. And that really serves as a prototypical patient for me as far as the kind of trouble that folks can get in with alcohol use. So let's talk a little bit about alcohol. How did this happen to Sheila? What are the reasons that she ended up in the situation where she is today? So alcohol use, incredibly common. More than 70% of US adults report drinking alcohol at some point in the last year. And globally, almost 20% of adults reported quote unquote heavy episodic alcohol use in the last 30 days. So that's a significant portion of the global population. And over time, especially over the last 20 years, we've seen a relative increase in alcohol use. So the top line is alcohol use at any level, going from between 40 and 50% in 1992 to greater than 70% of US adults reporting at least some use. And then you can see that alcohol use disorder and high-risk drinking are also increasing as well. And we do know that alcohol use is harmful. So globally, it's the second most harmful substance consumed. And the way that we measure that is in disability-adjusted life years. So a measure of a disease's burden on humanity and the number of years lost to illness, disability, or early death. And so what we know is that, in 2015, the attributable disability-adjusted life years were the highest for tobacco smoking, that was the number one, followed by alcohol, and then after that by illicit drugs as far as substances. And when we have an expert panel, as we had in the UK a couple of years ago, look at kind of the overall harms to society from various substances, people are most concerned about alcohol as far as expert panels, and they kind of divide up into harm to others, harm to users, how many people are using a substance, and therefore how many people it affects. Alcohol, basically always comes out as the number one most harmful of selected substances. Just briefly, as a physician, I've seen all of these conditions, and I'm going to go over some of the various effects of alcohol on the body. So, the brain, lots and lots of effects, disinhibition, depression, withdrawal seizures, confusion, dementia, trouble with balance, trouble with nerve pain, and numbness and tingling. We see head and neck cancer at an increased rate in people who consume alcohol. With the GI system, we see upper GI bleeding, we see tears in the esophagus from vomiting, we see difficulty with distended blood vessels, alcoholic ulcers, malnutrition, severe vitamin deficiencies. We see increases in rates of breast cancer among women who drink alcohol. We see heart problems, alcoholic and cirrhotic cardiomyopathy or heart failure. We see heart rhythm problems. We see problems with the pancreas, which can cause a severe chronic pain due to pancreatitis. Of course, the liver, either inflammation, scarring, difficulty with the blood vessels that filter blood and go through the liver, trouble with blood clotting, troubles with recycling blood cells, and then, of course, an increased risk of liver cancer. We see kidney problems, as we saw in our patient who came in, hepatorenal syndrome. We see difficulties with the immune system, and we see an increased risk of colon cancer. So all these put together, they're all things I've seen in people who are in the hospital. Really, alcohol is harmful to just about every tissue in your body, especially with prolonged and extensive use. But 70% of people in the United States report that they do consume alcohol at some point. So how do we know as physicians or as society members who is at risk for harm from alcohol consumption? So one way we can look at that is to measure how much alcohol people take in the form of standard drinks. And in medical school, we're asked to memorize this. A regular beer would be a standard drink, a slightly smaller glass of malt liquor, a standard glass of wine, or 1.5 fluid ounces or about a shot of hard liquor. However, when people are drinking and they're told how many drinks per day, they might not realize exactly how much they're taking in. A patient who says they have a margarita or two, that could be up to 6 standard drinks. And when we talk about malt liquor, especially in the larger bottles, it could be up to 8 standard drinks per bottle, and these are very inexpensive. So people can very quickly get to high numbers of standard drinks. What is high risk? This is something else that we're asked to memorize in medical school. So for women, they ask that you consume no more than 3 of those standard drinks per 24-hour period. For men, it's 4. For women, no more than averaging 1 per day over the course of the week, or 7 per week. And for men, 14. And we'll get into the reasons why it's different for men and women a little bit later in the talk. And so how did they determine this? I've always been really curious about what is this quote unquote safe alcohol level that I'm counseling my patients on. And so this is Dr. Lee, the director of the NIAAA, the National Institute on Alcohol Abuse. He said that their reviewers, in looking through the medical literature, found that the lowest total all-cause mortality occurs at the level of 1 to 2 drinks per day. And he specifically said that they're not endorsing any level of alcohol use. And there may be certain conditions where very low amounts of alcohol use could in fact confer some kind of protective benefit. But they said kind of in general, except for people at identifiable risk who have, for example, known liver disease from another cause, consuming 2 drinks per day for men and 1 drink per day for women, it's unlikely to cause problems. And that's how they came up with that number. As a physician, how do I decide if someone has alcohol use disorder? The definition from the NIAAA is that it's a chronic, relapsing brain disease. It's characterized by compulsive alcohol use, loss of control over alcohol intake, and a negative emotional state when not using. In order to diagnose this, I use the DSM-5. So the Diagnostic and Statistical Manual of Mental Disorders, 5th edition. And indeed, we really look at the 3 C's. The first one is cravings, strong desire for a substance. Do you need more and more over time to get the same effect? Do you feel sick when you stop? We look at control. Again, somebody who uses more than they intended, who tries to cut back, but they can't. They might spend time or money that they don't have on obtaining or using a substance. They continue to use the substance despite social or relationship consequences. And then we also look at consequences. So are they not meeting their job, their school, their family obligations? Does a person give up things they love to use a substance instead? Do they have health issues caused by the substance and continue to take in the substance? And then do they ever get into dangerous situations to use the substance or while using it? And so when I talk to a person, I would assess these. And then if they had 2 to 3 of these, I would probably diagnose them with a mild substance use disorder, 4 to 5 moderate, and 6 to 11 severe. what do we know about why someone might develop alcohol use disorder or develop alcohol use that causes problems in their life or with their health? So the way that I think about this as an addiction medicine specialist is that essentially there are these three components. There's heredity, there's environment, and then there's reinforcement. And these three things, they all come together in different amounts in each person, but they all kind of merge together to form whether or not someone will develop what we call the phenotype, or the way that somebody ends up displaying a condition. So let's start with heredity. So we do know actually that alcohol consumption level and alcohol use disorder, they are moderately heritable conditions. How does that compare to other conditions? So for example, it's slightly less heritable than type 1 diabetes, but it's more heritable than type 2 diabetes. All of the substances that we typically see people develop issues with, they are usually somewhere in the moderately heritable, meaning that it runs fairly strongly in families, but the fact that it's in your family doesn't necessarily mean you will develop it. There might be other factors at play. We're also looking at genes. So at least 18 candidate genes for high-risk alcohol use have been identified. And then they have at least 5 candidate genes for alcohol use disorder. And that science is ongoing. We also know that people with a family history of alcohol use disorder, they actually release more dopamine in response to the expectation of alcohol than people without any family history of alcohol use disorder. So something definitely at play there when it comes to how much somebody might desire to use the substance. Now we're going to talk a little bit about childhood trauma, because environment that people grew up in actually can be really, really important in whether or not they develop an alcohol use disorder or any type of substance use disorder. So we're going to talk about, and this is part of trauma-informed care as well. So we're going to talk about the Adverse Childhood Experiences study from 1998. Probably my favorite medical study of all time. I remember so well the day I learned about this in medical school. It completely blew my mind and changed the course of my career. So this was a survey in 1998 of over 17,000 Kaiser members. And, the physician who did the study actually was looking for a link between childhood trauma and obesity. And what he found was much more than that. So they put together these idea of 10 adverse childhood experiences, either physical, emotional, or sexual abuse, either physical or emotional neglect, and then different types of household dysfunction. Did someone experience someone in their environment with mental illness, somebody who was incarcerated? Their mother was treated violently in their presence. There was any kind of substance use or use disorders in the household, and whether or not there was family separation or kind of turmoil during their first 18 years. So what they found as far as how many people had these experiences was that about half of people didn't have any of these experiences, but a large proportion had at least one. About 1 in 6 people had at least 2, and then 6.9% of people had 3, and more than 6% had 4 or more. So fairly common to actually have these adverse childhood experiences. Now, when they put together the adverse childhood experiences and people's adult health using the Kaiser database, they found something extraordinary, which was that for every adverse childhood experience that someone went through, they had an increased chance of having just about any health condition. And that's, we see it the most with kind of the behaviorally mediated health conditions like substance use disorders, tobacco use disorders, attempts at suicide, mood disorders. But you also see it with things like stroke, diabetes, obesity, and high blood pressure. Just across the board, with every adverse childhood experience that stacks up, that person has a greater and greater chance of developing health conditions later in life. So for example, with 0 ACEs, a person might have 1 in 16 chance to develop daily cigarette smoking, but with 7 or more ACEs, it's going to be 1 in 6. With 0 ACEs, 1 in 69 people would develop alcohol use disorder, but with 7 or more adverse childhood experiences, it would be 1 in 6. Only 1 in 480 people with 0 adverse childhood experiences would use IV drugs, and 1 in 30 if they have 7 or more. And then 1 in 96 people who have 0 ACEs might attempt suicide. That number is up to 1 in 5 if you have 7 or more adverse childhood experiences. So you can see that this really affects what you go through in adulthood. With alcohol specifically, and you can see this graded response. So for every adverse childhood experience, you have a greater and greater chance of having these alcohol-related health issues, early initiation of use, a problem with alcohol use, identifying as alcoholic, or married to someone with an alcohol use disorder. And this slide is from one of the original ACE study writers. We also know that there's a critical period in the environment. So starting to consume a substance before the age of 20 is actually a risk factor for developing dependence or a use disorder later in life. And you can see that it varies by substance and that you're more likely to pick up smoking, for example, later in life. You can see the blue line is kind of above the other ones. But for alcohol and for other substances like cannabis, exposure during a period of brain development can actually predict the likelihood that you might develop a substance use disorder later in life. And then, once you're kind of through the heredity hurdle, through the childhood trauma hurdle, what happens when you're actually exposed to a substance? How do you react to it the first time? And so we do know about the neurobiology of reward, and that's what most of this is mediated through and what I study as an addiction physician. So there are these general parts of the brain. There's the neocortex, the rational or thinking brain, where most of the higher thinking takes place. There's the limbic brain, which is buried deeper inside, and it is mostly linked to emotions, feeling, reward. And then the lower brain stem is more like reflexes, control of blood pressure, control of breathing rate, some of the less conscious functions of our brain. We know that reward is primarily processed in that limbic system, so buried deep inside. And pleasurable activities, they cause release of dopamine in these areas. It can be measured on PET scan, it can be measured in animal studies in the blood. And so we actually see that natural rewards, they elevate dopamine levels. That's what drives us to do the things that'll keep us or the species alive. That's how our brains work. So you have your basal dopamine level, you have food, you go up to 150%. You have your basal dopamine level, you experience sex, you go up to 200%. That's quite rewarding. When we look at the effect of substances on dopamine release, yes, they are quite comparable. So, nicotine might take you almost to 250% of your basal level. Cocaine will take you past 300%. Ethanol, alcohol, is comparable to sexual activity in that it gets you to about 200% of your basal level. But the reward of a particular activity, it doesn't stay the same over time. So with more exposure, you get less and less of a dopamine release, which means that every time you engage in it, you still get a reward, but it's less pleasurable than it was the first time. And so that's where we get this allostatic model of addiction. That proposes that repeated exposure to a substance leads to long-term changes in the brain's motivational system. And essentially what we're saying is that the brain's thermostat, it's reset by a substance or experience that happens repeatedly to the reward center of the brain. And so instead of consuming the substance to feel good, it kind of resets the neutral point, and then you have to consume the substance to avoid feeling bad. That's what we call avoiding negative affect. And that's why we think that people who develop use disorder, essentially, in order to feel kind of normal or okay, or even less bad than they did before, they need to consume that substance. It's not optional to feel good. The way someone who's in a neutral state might consume a substance, they feel good, they go back to neutral. These folks, they reset their set point, they're feeling bad, they consume the substance, they can then feel neutral. So again, when I see patients, it's not usually one thing or another, it's a combination. I find that patients very frequently have a family history of substance use disorders of one kind or another. That probably sets them up for a certain kind of response when they are exposed to alcohol or other substances. They very frequently have childhood trauma, which again increases the chances that they're going to develop a use disorder. And then, it's about what they were exposed to at what point in their life and how they developed reinforcement, whether or not they consume substances on a regular basis and change their brain to then require that substance in order to feel okay. So talking specifically about women and alcohol, why are women unique when it comes to exposure to alcohol? And why are these patients like Sheila that I see such kind of difficult stories? So we do know that recent increases in alcohol use disorder, they're driven largely by higher rates among women. So between 2002 and 2012, there was a 35% increase in alcohol use disorder in men. There was an 84% increase in alcohol use disorder in women during that period. We also know that from 1990 to 2014, when you look at, you see on the right side, this is a rise in premature death. So death not at old age, not from natural causes. This is, deaths that should be preventable. And the lines across here are different groups, different ethnicities, different ages, rural versus urban. And in the United States, this top line is white women aged 35 to 39 who live in rural areas. They had the greatest relative increase in premature death over those 25 years. What is driving that? Well, it turns out that the greatest increases in cause of premature death were overdose, suicide, and cirrhosis due to alcohol. So why are women experiencing this? And how do women experience alcohol differently? What are the cultural forces that are leading women to have such a striking increase in alcohol use disorder over the last 25 years? And again, to have increased mortality compared to other demographic groups. So we do know that women face significantly higher rates of childhood sexual abuse, violent victimization compared to men and boys. And so their adverse childhood experience rates are different. And then, these higher rates of sexual abuse and violent victimization, those are the factors that produce the highest odds ratio for heavy drinking, for an earlier age of first drinking, and for the development of alcohol use disorder in the population in general. We also know that among adolescents who started to drink between the ages of 11 and 14, so pretty early age of onset, women progress to a heavy drinking episode more quickly than males. And so that suggests that when drinking starts before age 15, women are at a greater risk than males of progressing to that heavy drinking episode. We also know that women have kind of a unique relationship with substances that might help to alleviate negative feelings. So emotional distress, negative affect, or a state of emotional distress, it's an important component in the development of alcohol use disorder in women. Both when we look at it neurobiologically and when we do surveys of women and their feelings around their alcohol use. So what we see is that starting at puberty, whereas girls and boys before puberty have very similar rates of depression, it becomes twice as prevalent in girls than in boys, starting at puberty through late adulthood. We also know that women are more likely to report that they started drinking to treat emotional distress, to treat high stress, or to treat a mood or anxiety disorder, that women are more likely to consume alcohol to feel better, as opposed to men who often will report that they first started drinking to go from a neutral to a positive state. So if that makes sense, men report that they first started drinking because they were feeling okay and they like to feel good. Women are more likely to report that they were feeling bad and they want to feel neutral. We also know that women process stress differently, and there's a lot of neurobiology behind this, as well as measurements of cortisol and the HPA axis. But we know that stress and reward, they're intimately related, and there's a biological reason for that, right? Experiences that we go through while we're under stress, our body encodes them so strongly so that we can either remember strongly to avoid a negative experience or to seek out a positive experience, and that's evolutionary biology trying to drive us towards survival. And so we know that engagement in the stress system, it primes the reward system to encode these positive and negative experiences more forcefully into memory. And these are kind of the people, places, and things that are associated with something that stimulates dopamine. We also know that stress may actually accelerate the transition from this idea of controlled substance use to disordered substance use. And that men and women, they've been shown to have different biological responses to stress, as well as women reporting stress has a greater effect on their mood compared to men. So men might report other effects other than mood effects compared to women. One interesting aside is that bariatric surgery is actually a strong risk factor for the development of alcohol use disorder. So several types of bariatric surgery, specifically the bypass types, they change the body's metabolism of alcohol, and you actually have higher levels of alcohol in the blood occur faster, and you metabolize slower, so the levels stay higher for a longer period of time. We also know that increased alcohol consumption after surgery, it's associated with faster weight loss, which might be additional reinforcement for people who consume alcohol. They find that they are achieving their weight loss goals a lot faster. And so by year 3 after surgery, the risk of alcohol use disorder in people who have undergone bariatric surgery, specifically bypass types, it increases to twice that of the general population. And notably, these folks start out with a much lower rate of alcohol use disorder than the general population prior to surgery, because they have to go through such rigorous screening processes to qualify. And so people with alcohol use disorder generally are screened out from being candidates for surgery, and yet in year 3, we see twice the general population. And we also know that 80% of bariatric surgeries are in women. So specifically for women, this is a risk factor. I think we all know about the unique cultural influences that are happening right now as far as the mom wine culture. Drinking norms and values, they've become more permissive among women over the last 20 years. I was just in the mall the other day, and the entire display at one of the stores was all about moms drinking. It was all t-shirts and posters and wine glasses, and just really pretty extreme cultural shift. And there's kind of a theory that the unique stress associated with both pursuing a career and raising a family, because of the way that women report that they process stress, it may lead to increases in high-risk drinking and alcohol use disorder among women. We also know that alcohol has affected women pretty specifically in the time of COVID. So compared to men, women reported higher rates of pandemic-related changes in productivity, in their sleep, in their mood, in health-related worries and frustrations. We also saw that in some major surveys, psychological stress related to COVID was associated specifically with greater drinking for women, but not men. And I actually find this fact really interesting. They found that across the board, most people increased their drinking days per month, but that women specifically increased their heavy drinking days by 41% compared to before the pandemic. We also see that in women, there is a biological faster progression to harm from the same amount of alcohol intake. And that's where we get these numbers from, where women are supposed to be permitted to have 7 drinks per week versus men having 14 drinks per week with lower risk of adverse health consequences. We know that blood alcohol levels, they rise faster and they stay elevated for longer in women than in men. That has to do with your baseline metabolism. We also know that in alcohol withdrawal, the brain tissue of women, it shows more damage and inflammation during the alcohol withdrawal process. When they look at women coming into a detox facility compared to men, they actually found that women reported a shorter duration of heavy drinking and lower mean drinks per day, yet they tended to show greater elevations in liver injury markers. We also know, and possibly this is related, that women are more likely than men to take prescription drugs that can increase the risk of severe reactions, just having to do with women's prescription drug use in general. And then women have difficulties getting into treatment specifically. So among people with alcohol use disorder over the past year in the United States, 7.4% of men received treatment, which is pretty abysmal. But only 5.4% of women received substance-specific treatment. We found that women are actually more likely to seek care in non-substance-specific settings, possibly due to the stigma associated with alcohol use disorder, and specifically around alcohol use disorder and the role of a woman in the society. So they might go to primary care instead, and primary care physicians might not recognize the extent of disease. We also found that compared to men, women actually report less social support for treatment engagement and greater barriers to treatment access. So things like childcare responsibilities, a threat to child custody, social stigma, and a lack of economic resources all contribute to women having a more difficult time engaging with treatment in general, and with affording treatment when they are able to engage. So I am going to pass this off to Dr. Eric Geisler to talk a little bit about treatment. Let me stop sharing my screen. Okay. Awesome. Do we want to pause for any questions before we move on?
Okay, everybody. I'm Dr. Eric Geisler. You can trust me, I'm a doctor. I'm the medical director here at Serenity Lane Alcohol and Drug Treatment Center. And when you're from Eugene, everybody wants to know if you're a duck. And I'm not. I'm actually a penguin from Youngstown State in Youngstown, Ohio. And the other mascot there is Nate, the walking whale from my medical school. Ambulus cetus natans was the first mammal to walk on Earth, and apparently skeleton was discovered by one of our anatomy professors in Pakistan. And I don't know why they're both so angry. This is our beautiful facility in Coburg, Oregon. You saw the video earlier. Disclosures, I've been a one-time paid consultant to Alchemies Incorporated. They manufacture Vivitrol, an injectable form of Naltrexone, and I will be talking about that product later. I'll do my best to avoid any commercial advisement of that. I'm also a person in long-term recovery. I recently celebrated 30 years of continuous recovery from alcohol. This is my weak attempt to imitate my coin for 30 years. And this is me receiving an M&M for every single day of sobriety at 20 years. And I really appreciate the hair up here. The objectives today, we're going to do a very brief review of alcoholism as a disease because Dr. Marshall covered that. And then I want people to understand the treatment of alcoholism and its prognosis. I always start by recommending the Surgeon General's report from November 2016, Facing Addiction in America, basically said that alcohol and drug abuse are a major health concern in the United States. It's probably the smartest thing they said since smoking is bad for us. Alcoholism and addiction at Serenity Lane, we consider it to be a brain disorder that's chronic, relapsing, progressive, and potentially fatal. I like to think of it as similar to multiple sclerosis or Parkinson's disease. We can treat alcoholism and put it into remission, but I don't consider it a cure. If it's a disease, we have to understand what we mean by the disease. It means that there's an organ with some dysfunction that leads to symptoms, which is what patients complain about. And then they develop signs that are observable from the outside, whether it's family members or healthcare professionals. There might be some testing that's done. We make a diagnosis, we formulate some treatment, and hopefully improve the organ that's dysfunctional. In this case, the organ that's dysfunctional is the brain. And we like to say that the dysfunction is there's an abnormality in the reward and behavior cycle of people with this dysfunction, that there's just something different about how they respond to stimulus, especially from alcohol consumption or substance use, that's different than other people, that their behavior, especially repetitive behavior in regards to those substances, is different. If it's a disease, there should be some common clinical presentation. There's a genetic predisposition. In alcoholism, we like to say there's at least a 50% genetic predisposition. In the background population, about 1 in 8 people will have a problem with alcohol by age 25. That doesn't mean they're necessarily meeting the definition of alcohol use disorder, but they have some problem with alcohol by age 25. If there are first degree relatives in the family that have alcoholism, you can double that to somewhere around 1 in 4 or 25%. If you have 2 first degree relatives, meaning both parents or a brother and a father, you can double that again to about 50%. So, and then if you do twin studies where you look at identical twins. One grows up in an alcoholic home and becomes alcoholic, and the identical twin with the same genetic material grows up in a separate non-alcoholic home. Their chance of developing alcoholism is about 50%. So we like to say that there's about a 50% genetic predisposition to developing alcoholism. There should be some environmental factor that triggers the disease. We heard about the ACE score, and also first use seems to be a factor. People that begin regular alcohol consumption before age 18, you can virtually double their risk of having an alcohol problem by age 25. And then we'd like to know if there's some biological model that helps explain the disease process. The stages of the addiction cycle, the abnormal circuitry that I mentioned. There's the binge intoxication phase, followed by the negative affect phase that Dr. Marshall mentioned, where people feel bad. They don't feel normal. They feel poor compared to a normal state. And then they start anticipating the use of their substance, in this case, alcohol, in order to relieve that negative affect and to at least feel normal, or maybe feel better than normal, and they're back to a binge or an intoxicated state. In the alcoholic, we mentioned alcohol use disorder of a severe, and to define the word alcoholic, the Surgeon General used alcohol use disorder of a severe and chronic nature. Severe meaning they met the ASAM criteria for alcohol use disorder severe, having 6 or more of those criteria, and they define chronic as having those criteria for more than 6 months. So is someone ready for help? I know this is a disturbing image, but obviously this person is suffering and at risk. So what are the goals of treatment? The Surgeon General's report talks about this in one of the summary chapters. Is it detoxification? Is it maintenance of abstinence? Are we going to use a medication to maintain abstinence? How are they going to define recovery for themselves? Does it involve their physical health? Does it involve their family, community? Are they going to participate in a community 12-step group such as AA? And or are they expecting to have a spiritual experience? We start with detox, or what we call medication-assisted withdrawal support. The goals of this are to prevent seizures. Seizures can be life-threatening. Alcohol is a suppressant. It's a downer. And when we remove that downer, there's increased electrical activity throughout the brain. And if that electrical activity reaches a certain threshold, we'll have uncontrolled static or electrical activity throughout the brain with loss of consciousness, violent shaking, generally known as a grand mal seizure. That can be life-threatening. So our number one goal is to prevent seizures. Our secondary goal is comfort. Someone shouldn't have to be miserable to go through alcohol withdrawal. And we want them to be able to eat. We'd like them to be able to sleep. And we'd like them not to be chronically nauseated or throwing up. Medications we use, broad categories, benzodiazepines. These include things like Librium, Valium, lorazepam, and these mimic the neurotransmitter GABA. GABA is the neurotransmitter in the brain that's the down regulator, controls the brain from having excessive activity. And when we drink alcohol, it suppresses GABA. And then when we take that suppressant away, because alcohol itself is a downer, then we see increased electrical activity throughout the brain. So we use benzodiazepines to mimic GABA in the short term as the brain begins making more GABA after the alcohol has been removed. Sometimes if patients are also abusing benzodiazepines along with alcohol, then we may use a drug called gabapentin. Gabapentin is a medicine that forces the brain to make more GABA. It's FDA approved in the United States for seizures and for chronic neuropathy pain. It's not indicated for alcohol use disorder per the FDA, but it's commonly used for that purpose. So we'll use gabapentin in addition to benzodiazepine if necessary. The downside of gabapentin is it does take some time for it to soak into the brain and begin working. So it can take 24 to 48 hours for it to really take effect. There's older seizure medications, phenobarbital. Some hospitals still use phenobarbital. It's a barbiturate. It's a downer medication that also suppresses electrical activity in the brain. Its FDA indication is for seizures. And in Europe, they use a medicine called baclofen. Baclofen is categorized as a muscle relaxer in the United States. It's FDA indicated for muscle spasm associated with cerebral palsy, muscular dystrophy, or multiple sclerosis. But here in the United States, we rarely use it for alcohol use disorder. In Europe, they use it in massive doses for both detox and for alcohol relapse prevention. Some places use it in the United States as an adjunct to gabapentin. I will do that on occasion, but it's, again, not FDA approved for that. It's just a commonly used medicine. We always do this in the hospital setting. Again, our biggest concern is seizures. Those can be life-threatening. We worry about patients having a fall and hitting their head or breaking their arm, whether they're acutely intoxicated on alcohol or whether we're sedating them with benzodiazepines that are at increased fall risk. We worry about excessive vomiting and dehydration. This can lead to electrolyte disturbances and other medical problems like kidney failure. They may have medical complications due to their alcohol use. Maybe they have heart failure, maybe they have liver disease or kidney disease, some of the things that Dr. Marshall mentioned. They may have other underlying medical conditions that are aggravated by alcohol or by the detoxification process, things like hypertension, diabetes, and heart failure. And then there can be complicated drug interactions if patients are on medications for other chronic medical conditions, and we're going to add benzodiazepines or gabapentin to the regimen. We would want to watch carefully for interactions and side effects. And then there's other mental health considerations. Sometimes people do have dual diagnosis. Maybe they have bipolar disorder, or maybe they have a psychosis. And then when we remove alcohol as a downer, we get an emergence of their underlying psychiatric condition. So we talk about abstinence as a goal, coming from the big book of Alcoholics Anonymous. The idea that somehow, someday, the alcoholic will enjoy and control his drinking is a great obsession of every abnormal drinker. And this delusion, the persistence can be astonishing. And this is from Big Book, page 30. And once we've established abstinence, then we talk about maintenance medications. And essentially, there's 3 medications FDA approved in the United States for this purpose. The first one is naltrexone. Naltrexone comes generically as a pill that you can take every day, or it comes as an injection called Vivitrol. That's a long-acting injection that occurs in the buttocks once a month. It can be painful. Naltrexone is actually an opiate blocker, so it can interfere with patients that are on opiate pain medications, or it can precipitate withdrawal from opiate pain medications. But it can also block opiate pain medications if patients have an acute injury like a broken leg or they need to have their appendix out. So having this medication reversed can be complicated. It can also aggravate depression and aggravate elevated liver enzymes. And the Vivitrol is a brand name product. It can be very expensive depending on insurance coverage. So patients will say, well, why would I pick the expensive, painful shot in the buttocks instead of the generic pill? And the answer to that is because you can't untake it. If you decide on Wednesday you're feeling poorly, you've had a rough week, and you want to stop your naltrexone, then you can drink on the weekend. The long-acting version of the medication can get you through that weak moment and hopefully keep you from drinking in the first place. We do know that if you're on naltrexone, that the relapse rate's approximately 25% less in the first 6 months. It continues to have benefit for up to a year, but lesser than the 25% relapse prevention. We know that if you do drink while you're using naltrexone, it doesn't make you sick, but it makes days of heavy drinking less, and it increases your chance of getting back into an abstinence-based recovery. The other side effects can be nausea and some Disney-like dreams. I do have patients that are intolerant to the naltrexone because of that. You can start naltrexone virtually as soon as somebody's sober, and you analyze that their liver enzymes are within acceptable range. They're not too elevated. If you can't tolerate the naltrexone or you've tried it and it hasn't been helpful, then we can use a medication called Acamprosaid. The brand name is Cambral. It's a difficult medicine in that it's 6 pills a day. It's 2 large pills 3 times a day, and it can be quite expensive because it's a brand name medication. The compliance with that medication is poor, that less than 50% of people will refill it in months 2 and months 3 after starting it. The statistics of its success are similar to the naltrexone, and that we'll see a 25% reduction in the relapse rate. But again, it comes with poor compliance and a high cost. And antabuse is chemically disulfiram. This is a very old-fashioned medication. I call it Pavlovian dog training for alcoholics. If you're taking this medication and you drink, you will be violently ill, red in the face, vomiting, and not feeling well. I don't particularly like this medicine because it comes with a high risk of aggravating liver disease. And even in people that don't have underlying liver disease, it can cause liver failure in rare cases. So when you're on this medicine, you should have your blood work monitored monthly by your physician. And the outcomes data with antabuse is not much better than the Vivitrol, but it seems to have appeal for some people that have not been able to stay sober otherwise. I'll use it in that situation, but I rarely prescribe it for a new patient. Other medications we use for relapse prevention, sometimes we use Gabapentin to relieve symptoms of what we call post-acute withdrawal, ongoing irritability, anxiety, or insomnia related to alcohol withdrawal that can be seen for up to 30 days after an acute withdrawal. We sometimes use the baclofen that I mentioned to help with ongoing withdrawal and relapse prevention. The data on this is not as strong as the Vivitrol or naltrexone, but again, it's popular in Europe. And then some physicians will leave patients on low-dose benzodiazepines to manage their anxiety. I don't recommend this because I think that benzodiazepines can lead to craving of alcohol and relapse. So once we've stabilized someone medically, what else do we do either at the residential level or outpatient? Essentially, we break it down into some broad categories. We do cognitive behavioral therapy, and that breaks down into education, where we teach patients about the disease model and how it's affecting them and what outcomes could be. We also teach them about patterns of thought and behavior to help them recognize those patterns that might lead to a relapse of their alcohol use, and then change their behavior when they recognize those patterns. There's facilitated group therapy. This is usually done by a CADC counselor, where patients are instructed to share their experience and realize that they're not unique, and that help them recognize that it is a disease of the brain and it's not necessarily just bad choices. Mindfulness meditation, very good science here that if you put people in an MRI machine, functional MRI machine, inject them with a nuclear tagged sugar, and then show them scenes of their family and then scenes of violence, there's an area in the frontal lobe that lights up. If we do a 6-month course of mindfulness meditation, repeat that experiment, the part of the brain that lights up in response to alleviating the stress of that change in imagery enlarges. And what that tells us is that we can instruct the brain to interrupt that cycle of addiction, the negative affect portion that leads to craving. That part of the brain can be trained. and that if you complete a mindfulness meditation course, that we actually see a drop in the relapse rate of about 25% over a year's time, very similar to the medication naltrexone. And yes, you can use the two together and get a cumulative effect. I'd like to talk about the 12-step mutual aid meetings, commonly known as AA. And sometimes people now are going to mindfulness meditation meetings. These are basically based on meditation, have a group sharing meeting and then end with meditation. I think they're taking advantage of the science I just talked about and relieves some patients' discomfort with the religious language that's in most community 12-step meetings. We use motivational enhancement therapy, where we interview the patient in a way to help them see the benefits of them moving towards less use or abstinence. Exercise, there's lots of data out there showing that endorphins can help alleviate the negative affective state prior to drinking, and also lots of other benefits of exercise, weight loss, anti-inflammatories, etc. And then we also recommend trials of acupuncture, chiropractic care, or massage. There are some very specific acupuncture points and protocols that have shown great benefit in decreasing the relapse rate, helping relaxation and post-acute withdrawal symptoms. There's similar data for chiropractic and massage, but it's less vigorous. I talked about the cognitive behavioral therapy, recognizing patterns of thinking and denial. Some examples, this I call it good addictive thinking. Common ones, the last hurrah. People will drink a tumbler of vodka in my parking lot prior to coming into the hospital unit, or thinking I can just have one, I won't have a problem. Oh, it won't happen again this time. Or perhaps I'm marrying my fourth alcoholic. Why do I keep picking these same kind of individuals? 12-step mutual aid meetings, Alcoholics Anonymous. Most people want to know, does it work? And I say usually someone will yell out, only if you work it, which is a common phrase in the community programs. AA unedited or unreviewed data, they like to say if you're in your first meeting of AA, the chance of you getting 1 year of sobriety is 2/3. And there's a little footnote to that. It says, of those that are really trying. And what does that really mean? I think the modern phrase in the medical world was, these are people that are internally motivated. They're people that have been trying to quit drinking, but just cannot seem to quit drinking. And that data goes all the way back to the first 100 people that wrote the big book. Again, there's some unreviewed data that's been published on this by folks associated with Alcoholics Anonymous, that's the case. The medical literature does not support this. And then they say if you have 1 year, that your chance of getting 5 years of sobriety is about 2/3 again. And the unpublished data from Friends of AA, again, says this. This is a little more substantiated by the medical literature, that if you can get 1 year of sobriety, then your chances of getting 5 are pretty good. The medical literature says if you go to a first meeting of Alcoholics Anonymous and you do nothing else, the chance of you obtaining 1 year of sobriety, being internally motivated, you're really trying, is about 10 to 20%. There can be confounding issues around your treatment. We talked about the ACE score and early life trauma, comorbid mental health conditions, whether it's depression, bipolar disorder, or other conditions. There may be social instability in your family, employment, housing, transportation. These can all be challenges for people to maintain their sobriety. And then there's just the system in general. Can I get into treatment? Can I go to a meeting? Has COVID closed down my 12-step support network? And then how are you going to define recovery if we're going to take your alcohol away? And this ongoing obsession to drink alcohol normally must be smashed motto. We have to educate people that they're very unlikely to ever drink normally again. So with the prognosis, with treatment, what's our best outcomes? We can predict that there's an 80% long-term remission, best outcome. This data comes from healthcare professionals that are monitored in order to maintain their licensure, and that we know if they complete recommended treatment, inpatient, outpatient, and weekly recovery support with frequent random monitoring of their urines, that they can expect an 80% plus 5-year abstinent rate in retaining their license. If you want that kind of outcome, it's best to be involved in ongoing treatment and some kind of monitoring and accountability. But for most alcoholics, it's typical to have multiple treatment episodes throughout their lifetime, sometimes even with long periods of sobriety. And then finally, I like to end with the spiritual experience. This is Appendix 2 of the Big Book of Alcoholics Anonymous. And it says that Alcoholics Anonymous claims that if people can have a spiritual experience, they have a better than average possible outcome. And this definition comes after a patient named Ebby went to see Dr. Silkworth in New York in the 1930s. Dr. Silkworth was the alcoholic expert of his time, and with rare exception, his patients died. And I'll repeat that, with rare exception, all of his patients died. And that was the best doctor in the country at alcoholism in the 1930s. So Ebby saw Dr. Silkworth, and Dr. Silkworth said, "You're a miserable alcoholic. You're going to die a miserable alcoholic death." And Ebby said, "Well, is there no other hope?" He goes, "Well, you can go get a second opinion from a guy named Carl Jung in Austria." So Ebby got on a boat because there weren't planes. He probably drank his whole way across the Atlantic, saw Dr. Carl Jung, who was a contemporary of Sigmund Freud. They were neurologists because we didn't have psychiatrists yet. And he saw Dr. Jung for a couple of visits and asked him what he thought. And Dr. Jung said, "You're a miserable alcoholic. You're going to die a miserable alcoholic death." And he said, "Really, there's no hope for me." He said, "Well, only on rare occasion have I seen an alcoholic like you have what I can only call a spiritual experience, where you have a sudden and dramatic upheaval in how you experience life and spend your time. And I don't know how to trigger that, but I've seen it happen." So Ebby travels back to New York with this prognosis. He meets Bill Wilson, and this gets introduced into the big books of Alcoholics Anonymous, Appendix 2. And in that Appendix 2, you'll see where there's a book by William James called The Variety of Religious Experiences. And he goes on to describe 7 different types of spiritual experiences that can lead to a dramatic change in people's lives. And I would say that my own experience in treatment is that people that can have a spiritual experience do have a better than average chance of recovery. And it doesn't seem to matter what flavor spiritual experience it is, just that you have one. And then I have a list of resources here for those that are interested. And we're going to move to the question and answer period.
Dr. Geisler and Dr. Marshall, thank you both so much. I'm Stephanie. I'm the Community Relations Manager here at Serenity Lane. And I think I will just kind of start looking at some of these Q&As. Dr. Marshall, I know you already answered Maria's question that's in the Q&A, but for those who may not be able to see that, do you mind kind of summarizing? Maria asks, do you think that some women don't see that they have a problem if they drink heavily on weekends?
Sure, absolutely. So yeah, I think, it's interesting. I was working on a presentation on a plane not too long ago, and the person next to me was looking over my shoulder and said, "Do I have a problem?" And, we talked about it, and it is fascinating the way that people process and identify whether or not, and I think a lot of people kind of wonder, are they okay? And I think the question gets into the idea of binge drinking, right? And the idea that, if you're functional during the week, can you go wild on the weekends? And I think, part of the answer to that question, which I kind of put in the box there, is that I think people don't tend to know exactly what the recommended maximum is. And that for women, you can hit 3 standard drinks in a single strong margarita. And that would be your maximum recommended level as far as, kind of your body's inflammation, your capacity to process it over 24 hours. And that more than that might put you at physical risk. And then I think there's also the question of, what's going on in your life that's the reason that you're going to alcohol on the weekends, and how does that pattern of use affect the rest of your life? Are you having cravings? Are you having compulsion? Are you having consequences to either your health or to other parts of your life from that use? And so I think the 2 parts of that are what are the physical effects of drinking more than the recommended amount, even if it's just, once a month or once a year, or, what are the kind of diagnostic criteria for alcohol use disorder? And are you meeting those, the cravings, the consequences? So yeah, thank you for the question. It's a good one.
Yeah, I would
Thank you.
answer that to how are they going to respond to the information that they might be having an alcohol abuse problem, that they're episodically abusing alcohol, and be recommended that they stop that for health reasons or because it's socially jeopardizing them with consequences. And it's a fine line between episodic alcohol abuse and alcohol use disorder. And the literature would suggest that a strong recommendation from their physician that they cut back on their alcohol consumption generally is effective. And you can use motivational enhancement therapy where you ask them questions about how would their life be different or better if they didn't participate in this kind of behavior, and then challenge them to not drink and see how they do. The other thing I would mention is something called the Sinclair Method, where physicians or on the internet, you can read taking naltrexone before an episode of drinking will have you drink less. And I would tell you that if you read about the Sinclair Method, it probably is effective in people that have episodic alcohol abuse or alcohol use disorder mild. But in my experience, that method doesn't work by the time they're meeting DSM-5 criteria for alcohol use disorder moderate to severe. And so really it is important for somebody to tell them, yes, you're having a problem that you should cut back. And that has been shown to be effective. That's part of the cognitive behavioral therapy, that they recognize the pattern that their drinking is causing problems. And yes, you should do something about it.
Thank you both so much. Let's see, next up, Brandy asks, how often should one practice mindfulness in order to get a benefit?
The 6-month course they used in the study was a daily practice of 20 minutes, and recognizing that not everybody can do it every single day. So I think the average was 20 minutes, 5 days a week during the study. That's a lot of meditation, and it takes practice. And if someone were to do something along that, I'd recommend they get a coach or use one of the apps that are available.
Awesome, thank you. Maureen asks, I thought baclofen was similar to benzos with the potential for abuse. Great,
I'll take that question. That one caught my eye too. So I refer to baclofen as a benzodiazepine light. The actual receptor site where benzodiazepines attach has 2 parts to it, and the baclofen attaches to one part of it, and the benzos attached to both parts of it. So it seems to have more of a peripheral effect, attaching to the receptors at the muscles, which was where the nerves attach to muscles, which is why it got FDA indication for some of those other conditions. But it seems to have some central nervous activity at that other part of the benzo receptor. So yeah, it does have the potential to be problematic, which is why I think people steer away from it. Physicians steer away from it here in the United States.
Thank you. Have there been any medical studies regarding abstinence versus harm reduction?
I'm not aware of any for alcohol use disorder. Basically, the studies I was talking about with naltrexone was more about relapse prevention, returning to behaviors that would qualify you for alcohol use disorder again. But as far as harm reduction to the rest of the community, I'm not aware of those studies. Kate, you might be.
Yeah, I couldn't quote any specific studies either, but I know that, from the standpoint of the addiction physicians that I work with, harm reduction is always a worthwhile goal. And if you're forced to choose between somebody engaging in harm reduction versus not being able to achieve their abstinence goal and then returning to heavy drinking, harm reduction might be better. Harm reduction is an interesting concept because with other substances, it's almost the method of ingestion that causes a lot of the harmful effects. So we think about it's actually the physical injection or the smoking that causes a lot of the consequences. And so if you can encourage people to use a safer route of ingestion, that harm reduction can be really helpful. With alcohol, the route of ingestion is pretty much always the same. And so you can't really apply harm reduction to route of ingestion. And so I think harm reduction would be kind of, cutting back on the amount of exposure to alcohol, which I think in any case would definitely be beneficial. I think, and I was reading a couple of papers from some of the liver societies about whether or not a harm reduction approach can be helpful when looking at transplant candidacy. And really, it was pretty equivocal. They didn't come down strongly on either side, but they did find that even when they waived the 6 months abstinence requirement for liver transplant, there was a significant portion of people who had a return to use. And so it was, they kind of felt like, yes, that would be a harm reduction approach, but that a significant portion of people don't really see the benefit of the liver transplant, unfortunately.
Thank you. This is a great question from Jeffrey. I read that anxiety and mood disorders are the #1 reason for women to seek treatment, and substance abuse was second. For men, this was the opposite. This was from the Anxiety and Phobia Workbook by Bourne. Do you think this is true? And if so, how close are women approaching men as substance use disorder as the leading cause of seeking treatment?
I think
I don't have any specific figures on that. I find it completely believable. And I think it really speaks to the different ways that men and women might process stress, might process negative experiences that they go through, and the ways that men and women go through society with different kind of stigmatizations on different behaviors. And so I find that, I find it fascinating, and I think it really plays into some of these mood disorder as a reason to seek treatment. I think it plays into women seeking primary care more as well. Whereas there might be a masked substance use disorder underlying their reason for seeking care. They may say that they're depressed or anxious, and actually there is significant substance use in the background. So yeah, that's really interesting, and I find that very believable.
Yeah, I would say that if you read the DSM-5 carefully, it usually says in the absence of alcohol or substance use in a certain time frame, because I think that doctors in the primary care setting have a really difficult time making an accurate diagnosis when there's a substance use disorder that's hidden. And it's really hard to say that somebody be accurate saying they have a generalized anxiety disorder if you don't know that what they really have is untreated alcoholism, and they're experiencing episodes of withdrawal between bouts of heavy alcohol drinking. And I think that's also true for some of the other affective disorders, depression and bipolar. I think a lot of them those diagnoses are made in error according to the strict rules of the DSM-5, because there is acute substance disorders going on. And that's usually one of the biggest questions we get when people come into detox and residential treatment is, do I need to stay on my antidepressant? I haven't really been taking it all that well anyway, or my anxiety is through the roof when I come off alcohol. And we have to educate them that, well, a lot of your anxiety is actually alcohol withdrawal, or, more commonly marijuana withdrawal, because it has such a late onset. So you have to really reevaluate those diagnoses once somebody has 30 days or more of sobriety. And that's one of our rules with our psychiatrist. He likes to see people at week 2 of their residential treatment, because he's more likely to get an accurate diagnosis at that point.
Great, thank you. Tim is asking, there have been recent news articles about using psychedelic drugs in guided therapeutic settings. Do you foresee this being a part of a regimen to induce or encourage a spiritual experience in alcohol treatment?
Excellent question. Probably you've read the book, How to Change Your Mind. If you haven't read that book, it's an excellent history of this subject. There were really good studies done in the 1950s at an alcohol treatment center in Saskatchewan that demonstrated that triggering a spiritual experience with a psychedelic seemed to improve abstinence outcomes from alcohol. And those studies are being repeated. And hopefully they are well done with large enough numbers that they'll be validated, and we'll have some guidance about how to proceed forward. I am not a fan of the law that was passed in Oregon, because I think people are going to do that experiment on their own and with less controlled environment and potential hazards. So I'm curious, I'm optimistic, I'm hopeful that maybe someday I'll have a treatment regimen in my treatment center that involves specific dosing of psilocybin in a controlled environment. But we're a long way from there at the moment.
Yeah, my mentor Todd Korthus is on the Measure 109 board, and we had a presentation on it, and the implementation process is pretty fascinating. They're taking a good chunk of time. It's at least a year to do a thorough scientific review, and then determine kind of who will be eligible for licensure to prescribe these substances. And I agree. I mean, I think it's a fascinating prospect, and so far there have been a couple of promising studies. And but yeah, I'm very fascinated to see how it develops over time.
Thank you. Angela asks, historically, what changed and when for women drinking being okay?
So this is a great question, and my joke answer is Sex and the City, but I think the real answer is that our country is in cycles of approval and disapproval of substance use. We are in our third great cycle of liberalization since the Second Great Awakening, which happened in the 1830s, 1840s. And each cycle has had its own kind of ups and downs and has added substances, and more substances are developed. But the first great cycle was actually in the mid 1800s. The second was when Prohibition came about. The amendment was introduced in 1914, and then went through in the early 20s. And women actually were a big part of that temperance movement. And the disapproval of this idea of saloons and intemperance. However, women were also a big part of repealing that law, because there was a lot of misinformation given to them around, they thought that saloons would be banned, but that drinking in the home would not. And drinking in the home was actually really important to a lot of women in the 19 teens. And so, I find it fascinating, the role of women in alcohol over the course of these great periods of liberalization and kind of tightening down in temperance. I think it's probably part of a liberalization in general in our society, and part of kind of women striving for equal treatment toward men, which is difficult in the context of these biological differences, I must say, to reconcile, because women are in the same environments as men in many cases and are consuming the same things, and they may have more damage to their bodies as a result, which is something that may not be widely realized. So, you have thoughts, Dr. Geisler? What changed? When did the wife mom culture come around?
My biggest thought was, prohibition. Most people don't realize that the production and sale of alcohol was federally outlawed for 12 years. And, if we tried to do that today, there'd be riots in the street. And I think we're at the end of prohibition of cannabis now too. So it'll be interesting to see how that evolves. I can't point my finger at any moment either. Certainly I've been a witness to it in my career and in my personal life from college forward. But what, I can't put my finger on it either. It's a cultural phenomenon, so I think we'll see the same thing with cannabis all across the board, men, women, both. So.
That was fantastic. Thank you both so much. I'm going to kind of make some wrap up comments here. Did you guys have anything you wanted to close out with before I kind of end with some logistics?
Oh, I just want to say thanks for having me. It's been great.
Thanks everybody for taking an hour or more of your day to listen and learn as much as you can.
Thank you both so much for being present and doing this with us. Thank you so much, Dr. Marshall and Dr. Geisler, as always. If you are, we will send out, if you're logged into this call, that means you registered and we have your email, and we will send you a link to an evaluation. If you fill out that evaluation, we will follow up with a certificate for 1.5 CEUs through MACBO. With that, hopefully we'll keep you informed of other upcoming webinars that we have going on. And if there's anything you'd like to see, please make sure you put it in the notes of that. We'll stay here for just another maybe minute or so in case there's something exciting that comes in, or you have that last minute burning question. There's a lot of thank yous coming in through the chat. Steve Harris and Carrie also Evans put their information in the chat. They're great to reach out to in case you need any more information about Serenity Lane. We will include that as well in the evaluation. So thanks, agreed, it was wonderful. Okay, thank you guys all for being here today. Everyone have a fantastic afternoon.